right. Well, I'm just going to say good morning or good afternoon to everybody wherever you are. My name is Haytham Kafarani. I'm one of the trauma surgeons at Mass General Hospital and Harvard Medical School and the director of the Center for Outcomes and Patient Safety in Surgery, or COMPASS. And it gives me absolute pleasure today to introduce our speaker for our quarterly webinars. And we have Dr. Gelb Safran. She is an internationally recognized healthcare executive with a unique blend of accomplishments in both business as well as academia. A central figure of her work has been combining the science of quality measurements with the art of its use to drive significant change in the quality outcomes and affordability of care. Her prior roles include a whole load of very impressive roles, including being a senior executive at Blue Cross Blue Shield, where she was the lead architect of the Blue Cross Blue Shield Massachusetts Alternative Equality Contract, among many, many, many other achievements. Dr. Safran is an amazing speaker, and she's going to be talking to us today about the next generation quality and safety measures and give us some intel inside payment reform. And I'm gonna, before I give her the chance to share her slides and start, I want to make sure encourage all of you to be very interactive, to bring your perspective, to ask all your questions in the Q&A, and I will try my absolute best to go through all your questions in the end. Dr. Safran, please go ahead.
Thanks very much. It's really a privilege and a wonderful opportunity to speak to this group today. If only we were in person, but probably we wouldn't have the opportunity to have so many of you if we were. So very, very happy to be here and looking forward to the discussion section. Thanks for the very generous introduction. And I will try not to disappoint. So let me first just pull up my screen and make sure that that's working okay for everyone. Oops. Okay. Are you seeing my cover slide?
It's perfect.
Okay, fantastic. Well, good. So there are just a couple of sections that I have in mind for us to discuss today. First, I'm going to start off by, for those of you who don't spend your days and nights thinking about quality measurement and improvement, I'll just share a little bit about the genesis of the field of quality measurement. And how that led to the creation of the National Quality Forum, which I have since August had the privilege to lead. Then I'm going to talk about value-based payment as what I see to be one of the absolute most important and valuable levers that we have for advancing quality outcomes and affordability in our healthcare system. In that section, I'll share quite a bit from my own experiences leading value-based payment work at Blue Cross Massachusetts. And from there, really talk about what I see as the imperative for getting to a next generation of measures in order for value-based payment to be successful. I'll say a little bit about how I hope NQF will fit into accelerating the development and adoption and use of that next generation of measures. And then finally, I want to conclude by talking about the very important and timely issue of social drivers of health. I think value-based payment has really elevated our awareness of the social drivers of health. And we are in the midst of really important discussions about how those should get accounted for in value-based payment. And I think that's such an important and relevant topic. So I'll say a little bit about that as well. That's where we're going, a little bit of a roadmap. And let me then move to the first slide. So it was about 1999 when the field of quality measurement began to become something that was more than an academic exercise. There had for about a decade or a little bit more at that point been large, important studies that were developing and validating measures of healthcare quality. But up to that point, those measures were largely relegated to use in studies. Suddenly, there were a number of very important reports, and you see some of them represented on the screen here, that began to call our attention publicly and to policymakers, and even to those in the delivery system as providers or payers, about some of the ways that we really need to address quality and quality improvement in US healthcare. So I would say first among those came the 1999 report called To Err is Human, and you see that pictured here. That was a report by the Institute of Medicine, now called the National Academy of Medicine, that woke us up to the significant place that medical errors play in morbidity and mortality in the US. Finding that the number of deaths associated with medical errors was equivalent to if a jumbo jet airliner filled with passengers crashed every day of the year. That was shocking and a real disconnect from what most of us walked around thinking about our healthcare system, which is that we have the best system in the world. So how could this be true? Then came the Institute of Medicine's report called Crossing the Quality Chasm, which outlined 6 pillars of a high performance healthcare system: safety, timeliness, efficiency, effectiveness, equity, and patient-centeredness, and said that there wasn't just a gap, but a chasm between where we are and where we should be in order to have a high-performing healthcare system. That framework remains today, I think, one of the most important and enduring frameworks around what do we even mean when we say quality. At a similar time, Dr. Beth McGlynn and colleagues from RAND published a very important paper in New England Journal showing that only about half of the time were adults in the US getting what care was recommended based on their clinical and demographic status. And so in 1998, then President Clinton convened a commission to evaluate the ways to protect consumers in healthcare and to advance quality in the healthcare system. And it was this report that was the genesis of NQF's founding, because at the time, the measures that had been developed in academic studies that I referenced a moment ago, and other measures were so numerous, and there were questions about, how are we going to harness all of this measurement, and how are we going to be sure that the measures that we're using have good science behind them and are good enough to be used for what I, in my academic work, had called high stakes purposes, things like payment or public reporting or network design for health plans. And so that was the genesis of NQF's creation, was that Clinton Commission report. NQF was established in 1999. We have been, since then, a multi-stakeholder member organization, public and private, driving measurable improvements in healthcare. We have 2 core functions that we serve since that time. One is to be the body that's responsible for considering whether measures have adequate science and value behind them to be endorsed. And we'll say a little bit more about that in a moment. And another is a role that we play for the Medicare program that falls under something called MAP, the Measures Application Partnership, where we review every year through a multi-stakeholder set of committees the measures that CMS is considering for inclusion in its programs, and advise CMS on which of those measures this multi-stakeholder group recommends be included and which not. Despite, I would say, enormous progress, there is still obviously so much to be done. COVID has, I think, shined a bright light on some of the vulnerabilities in our system. I'm sure all of you who come from provider organizations are experiencing that, both in terms of the workforce vulnerabilities and the crisis that we face with workers in healthcare settings departing those roles, nursing in particular, but also the vulnerabilities, of course, that we've seen in our patient populations and And out of that has come, I think, an even more robust conversation about the importance of health equity, which, as I mentioned, the Institute of Medicine report in 2000, Crossing the Quality Chasm, put forward as one of the 6 pillars of a high performance system. And of course, the other enduring issue is we have a healthcare system that is the most expensive on the planet. We spend about twice as much as other nations with advanced economies, and yet we have some of the lowest rates of health outcomes, highest rates of chronic illness, highest rates of premature death, lowest life expectancy among advanced economies. And so how do we address all of this? As I indicated, I think value-based payment is a critical lever, but there are other levers. And this framework that I developed as I arrived at my role at Blue Cross Mass in 2006, identified 4 main ways that a payer or even a provider system, a purchaser, could use data and measurement to advance quality outcomes and affordability. The first measure or the first approach is simply holding up the mirror, right? Showing a provider organization, a provider group, even an individual clinician, how they perform on a given metric relative to benchmarks, relative to peers, et cetera. That is not a high stakes use of measures, and sometimes has some impact, but rarely closes the gaps that we try to close. So then we move to 3 different, I would say, increasingly high stakes ways of using measurement. The first of those 3 is you can attach dollars to the measures, paying based on performance. And we'll talk quite a lot about that over this hour. Second is you can build the measures into transparency tools or other ways to publicly report the information, so thereby attaching reputations to the measures. And finally, and perhaps most high stakes of all, you can attach market share to the measures by building them into benefit designs. So we all know about tiered network benefits, about select or narrow networks that increasingly are in demand from employers and purchasers of health benefits for their employees. And so these constitute, I think, the 4 main levers for using data and information to improve quality. NQF uses 4 broad types of criteria to evaluate measures for endorsement. First, the assessment is made as to whether the measure is important, whether it's scientifically acceptable. So from a psychometric perspective, is the measure reliable and valid? Reliable meaning that you would get the same results for a given unit of measurement, whether that's a clinician or a hospital or anything in between. If you measure it again and again, would you get the same answer? That tells us the information is reliable. Is it valid? Is it measuring a construct that is telling us something that we know has validity, is credible? The third criterion is the information usable and relevant? And you can see that the broad set of stakeholders for whom it's intended to be relevant. And finally, the feasibility of the measure. And quite a lot of emphasis on this issue right now because of the increasing importance that measurement is playing in our payment models, in our healthcare system. There's a very keen awareness of the burden that this places on those who are providing care. And we have to strike the right balance between the data we need to assess the performance of our systems and to create accountability around that performance, but at the same time, not to be burdening the system to the extent that it's difficult to get the core work of healthcare done. So here I thought, knowing that this audience might include a lot of surgeons and those who work in surgical departments, I thought I would share, one example of how performance-based payment in the relatively early years, these data are old from 2010 to 2014, but how measures of hospital-acquired conditions really help to both prevent harm and save money. So you can see here that the evidence showed 87,000 fewer deaths associated with beginning to pay for performance on hospital-acquired conditions, and about $20 billion saved in that 4-year time period. Interestingly, you can see, and this might surprise you, it definitely surprised me, that roughly half of that were savings associated with reducing the incidence and severity of pressure ulcers. But then you can see next highest, reducing the occurrence of adverse drug events. Important here for this audience probably is about $1 billion saved by reducing the severity and prevalence of surgical site infections, central line infections. So a lot of value happens both in terms of dollars saved, but obviously much more importantly, harms avoided and even deaths avoided. So just a couple of words about NQF and our future, and then I'm going to switch to talk about value-based payment, which really we wanted to have as our main focus today. In December of 2020, which was before my time leading NQF, NQF published a new strategic plan. I mentioned that we have had two core functions, the function around having responsibility for the country's portfolio of quality measures, the endorsement and maintenance of that portfolio of measures. But in addition to that, the work on the measures application partnership advising CMS. This strategic plan envisions NQF playing a role that's broader than that, what I've described as upstream and downstream from the endorsement process. And you can see here 6 outward-facing goals around the health of our mission to support moving toward a next generation of measure architecture, advancing health equity, ensuring patient-family engagement, supporting the success of value-based care and value-based payment, which is what we'll talk about, the importance of transition to digital sources for measurement, and of course, closing high priority quality gaps. And then 6 goals that are more inward facing to NQF around the health of our workforce and the health of our organization. And so this is really that vision of working both upstream from where measures are endorsed and downstream to where endorsed measures are used to help drive improvements in quality and outcomes, affordability, and equity. So let's talk a little bit now about payment reform. I'm gonna just keep an eye on the clock here to make sure that we reserve plenty of time for your questions and for discussion. But here are some data that probably you've seen before and that I referenced in my speaking points, but if you haven't seen the data before, I want you to have this visual image. These are the data that compare US spending on healthcare to other economically advanced nations. And what you notice is that since 1980, and for every year since, US has spent more than our economic comparator nations by a lot. And importantly, that our rate of rise, the steepness of that curve on our expenditures is much steeper than others. So we spend roughly twice as much as many of our comparator nations, and our rate of rise has been about twice that. So we are really spending ourselves off a cliff. And if all of that spending was getting us the healthiest population outcomes in the world, then I think that might be seen differently. But as we discussed before, it isn't. And this represents an enormous burden, both for the public sector, but also very, very importantly for the private sector. And you've seen private sector purchasers, employers, getting more and more innovative and activist about how to address affordability. And occasionally we see spikes of discussion about the possibility of the end of employer-sponsored insurance. Ultimately, that hasn't happened. I personally don't anticipate that it will. I spent a couple of years after Blue Cross sitting on the purchaser side of the table, working at Haven, the joint venture of Amazon, JP Morgan Chase, and Berkshire Hathaway, three Fortune 10 companies that came together to try to transform healthcare, both because of this cost problem and because of the value problem, feeling that they're just not getting what they need for their employee population, despite the rises in healthcare spending year after year after year. So I think probably this audience understands this, but just to level set for those who might not have a background in value-based payment, on the left you see a kind of depiction of fee-for-service payment, which is what it sounds like it is, right? We pay for each and every service, regardless of what results arise from that service. So that's our traditional model of payment. On the right, we see a depiction of value-based payment, where there is a population for whom a provider organization accepts accountability, and as a result of that accountability receives a budgeted sum of money, whether that's for a condition or an episode, or for global care, end-to-end care for the population, a budgeted sum of money. And then typically what's meant to be represented by the right part here, additional funding based on performance, both performance on the budget, but also performance on a broad set of quality and outcome measures. So here what I'm showing you is from the Blue Cross Massachusetts Alternative Quality Contract, what were some of our results with respect to quality? Now, I'll just take a moment for those who aren't familiar with the AQC to just give a little bit of background about it, because it played a central role in the emergence of value-based payment in the US and even internationally. So it was 2007 when Blue Cross Mass began to develop the Alternative Quality Contract. Our goal at the time was to find a voluntary and to define a voluntary model of payment that would do two things. It would slow the rate of rise in healthcare spending at the same time as improving quality and outcomes for our 3 million members. And it was that simple, although obviously that is the holy grail of healthcare, right? How do we improve care and outcomes while reducing cost and cost growth? And the Alternative Quality Contract is the model that we developed that studies by Harvard Medical School have actually demonstrated did accomplish those twin goals. It did reduce spending and cost growth, and it did improve quality and health outcomes. And roughly just an overview how it did that with a global population-based budget. So provider organizations who accepted accountability for end-to-end care, for everything from prenatal care to end-of-life care and everything in between, and who had two-sided risk for that spend. So if they spent less than their budget, they shared in the savings. If they overspent their budget, they shared in the deficit. And a counterbalance to any impulse to stint on care that's represented by a budgeted model came through our having a robust quality measure set. And that quality measure set included ambulatory and hospital measures. And in both settings, it included process, outcome, and patient experience measures with a unique model of behavioral economics that incentivized improvement every step of the way. And that incentive model, which we can talk a little bit more about during the Q&A if folks are interested to learn more about it, really was very different from how pay for performance had been done up to that point. And really, I think, changed the way performance-based payment in healthcare was thought about. I have the incredible privilege to sit on the Medicare Payment Advisory Commission, or MedPAC, and have been able to bring the basic principles around design of those incentive structures to MedPAC and I'm very proud that MedPAC's approaches recommended to Congress and to CMS now incorporate some of that. Well, all of that was represented in the way that we structured our incentives here at Blue Cross Mass results. And what you can see, the blue here are the results we got in our first few years of the AQC, and the orange represent national benchmarks. Remembering that the AQC started in 2009, so each of the first two data points are the lead up to the AQC, at which point providers may have been getting ready, knew that they were coming in, but weren't yet in the contract. And what I would draw your attention to is, in particular, the third panel here with health outcomes. And why I say that is because up to this point, we and other payers had begun to have process measures of quality in our contracts, though the dollar amounts available to be earned were pretty small. In the AQC, those dollar amounts were much higher, and there were process measures. That's most of what's encompassed in these first two panels. But one of the things that we did that was unique was to create accountability for outcomes, to create accountability for things like blood pressure control for patients with hypertension and diabetes, and hemoglobin A1C control for diabetics, and cholesterol and blood pressure control for cardiovascular disease. And what you'll notice was that from the time that organizations started the AQC over the first several years, they were able to accomplish remarkable improvements in these health outcomes, while nationally, really nothing was changing. You'll also notice that before the AQC, these organizations were at about the same level of performance on outcomes. And this level of performance, having roughly 60% of adults with chronic illness under poor control, is really a significant problem, right? To have 40% of adults in poor control means that we are setting ourselves up for the negative health consequences that come with hypertensives and diabetics and those with cardiovascular disease and other chronic conditions, not having those conditions well controlled. And you all know what those are. They're heart attacks and strokes and kidney failure and blindness and death. So to be able to achieve this kind of improvement in a brief period of time was really striking, and something to this day I remain very proud of. And the way that it happened really is that the model, by its nature, asks providers to begin to focus outside the four walls of the healthcare setting to where patients live and work and lead their lives. Because you can't be successful on the cost side, managing total cost of care, or on this health outcome side, if you aren't thinking outside of that literal and figurative box of the clinical practice setting to where patients' lives actually take place. And we'll come back to that because I think that's where the value-based payment movement has really begun to bring social drivers of health into the conversation about healthcare, because you really have to begin to consider those things as you aim to be successful managing total cost of care and improving outcomes. This is just to illustrate that the Harvard Medical School team that was studying the AQC was publishing results on our cost and quality outcomes from the very first year and all the way through 8 years into the initiative. And so a number of articles, about 24 articles about the AQC, but these three kind of anchor articles about the overall quality and cost improvements published in New England Journal of Medicine at the 1, 4, and 8 year mark. But here's some evidence from CMS national programs. So what I'm showing you here comes from a Medicare report published last June. And I divided it into 3 different categories of payment models. There are population-based payment models, or ACOs, which, like the AQC, ask the provider to be accountable for everything from prenatal care. Well, I guess you don't have prenatal care for Medicare beneficiaries, but everything from preventive care to end-of-life care and everything in between. Episode-based models, and primary care transformation models. And you can see the number and names of the models here. And what I've also shown you is what happened with respect to cost and what happened with respect to quality in these models. Two different kinds of cost indicators. One is from a perspective of gross savings. Did the model save money? But then also after paying shared savings and quality bonuses, did the model still save money? So what you notice is that basically the broader the model, the better the results. So the models that asked the provider system to be accountable for the whole population and every kind of care, really were the most successful. All 4 of them had gross savings, and 3 out of the 4 of them had net savings, even after paying shared savings, even after paying for quality bonuses, they saved money. And they had some improvements in quality. I'll say, not the kind of significant improvements that we saw in the AQC, but some improvements in money, in quality, and that was a good thing. You can see somewhat less compelling cost results for episode-based models. 5 of them, all of them with gross savings, but only 1 of them, after paying bonuses, actually saved money. And some lackluster results for the models that were focused just on primary care. That probably doesn't surprise anyone, because as critical as primary care is to driving the totality of care, when what a provider system is accountable for is only the primary care piece, that's such a small piece of the pie that it's not a surprise that overall it doesn't drive savings, and unfortunately didn't drive a lot of improvement in quality either. So I want to transition now to talking about the measures that are so central to these models being successful, right? Because if we want value-based payment to deliver both affordability and a system that's delivering improved health outcomes and better quality within the system, then we really need to move from the generation of measures that grew up out of fee-for-service payment, which are largely process measures, or what I've called in some of my work little dot measures, to big dot measures, measures of outcomes. And part of why this is so important is if you think about the accountable care organization or the global budget types of models, a provider organization that's accepting accountability for everything from end to end, if we're going to measure that based on process measures, that is just a kind of unfathomable number of measures. And it gets us back to that issue of burden. If instead we are going to say, look, with value-based payment, we don't want to micromanage what you're doing to get good results. We just want to create the accountability for getting good results. And you define what the best care processes and care models are for getting to those results. So we need these big dot measures. And, I would say in an ideal world, we have, a big dot measure for cost, for quality, and for health. And in fact, we do have a big dot measure for cost for the models that are in play today, total cost of care models for measures rather for ACOs or for bundles. But we don't have a big dot measure for quality or for health. And maybe at some point we'll get there. But along the way, we can get to something that gets us a little bit closer, and that's rolled up from process measures and frankly, more meaningful to patients, to purchasers, to those who are experiencing the outcomes and paying the bill. So the problem is, even though we have had about a decade of consensus that we need more outcome-oriented measures in order for value-based payment to live up to its potential, we have very little in the way of outcome measures in the NQF portfolio relative to process measures. We actually have quite a number of outcome measures in our portfolio, but many of them, a large percentage of them even, are measures of readmissions, hospital readmissions, a critically important issue, but it leaves open so many important outcomes for patients who are, not in the hospital, who have a chronic condition being managed in an ambulatory setting. And in particular, these 5 broad clinical areas represent 50% of spend for Medicare as well as for commercial payers. And yet there's almost nothing in the NQF portfolio that payers can use to represent the outcomes for these 5 broad clinical areas. And so that, I think, is a compelling need. And I'll tell you in a few minutes about a way that NQF is hoping we can help accelerate the adoption of measures in this space. But first, I want to focus for a few minutes on one type of measure and some learnings I had, again, from my Blue Cross experience. I'm going to talk a little bit about patient-reported measures. So that's, this category that I'm highlighting here, patient functional status and well-being. This is patient-reported information. All of you probably are aware that these kinds of patient-reported measures are the bread and butter of clinical trials today. They are, for drug development, for device development, really critical to how we know if we have an effective product. If we're trying to develop a migraine medicine, how would you know if it's effective? Unless you're asking about headache pain before and after. If you are developing a therapy for patients with arthritis, how would you know if it's effective if you aren't measuring their functional capabilities before and after? So functional status measures are one very important and highly used area of measurement, but they really haven't found their way into day-to-day clinical practice for the most part. There are some exceptions, both at the institutional level. There are certain institutions that really have embraced what's called PROMs, patient-reported outcome measures. And there are certain clinical specialties, and I would say orthopedics is probably foremost among them, that have really embraced the use of PROMs to assess how patients are doing and how interventions are helping them. But for the most part, these measures are used more in studies than in actual care. And so in my work this slide here, which I'll jump over now, really just explains, well, what are patient-reported outcome measures? So I've just told you that, and I'll move on. But in my, in my work at Blue Cross Mass, when we were about 5 years into the AQC, and we had the same measure set that I had developed in 2007, I was getting really frustrated that nothing more was coming through the NQF pipeline that we needed that were more big dot measures. And so because I had been in my early years a measure developer myself, and now had a network of providers, including Mass General Hospital, that I could engage in the use of patient-reported outcome measures, we made this a new and voluntary part of the contract for providers to work with us to begin to implement into day-to-day clinical practice PROMs for select, ultimately 6 different clinical areas. We started with 2. We started with depression and hip and knee pain, and then expanded ultimately to 6. And we learned a tremendous amount from that. And I would say did a lot of good because it changed the clinical dialogue in ways that clinicians told us really enhanced the experience, and patients, we know, really felt enhanced the care they were getting too, because the clinicians were talking to them about how they were doing, how they were feeling, how they were functioning, and actually measuring that and measuring the change over time. Well, one of the things that we learned out of that, which I will share with you on the next slide, I just find it very compelling, is that PROMs also often can be a very important indicator of whether a particular intervention is the right intervention for a patient or not. And what I'm showing you here are data for patients who had hip pain and ultimately had a hip replacement procedure. The baseline functional status of the patient is on the x-axis, and the change in functional status after the procedure in the first 6 months is represented on the y-axis. And so what you'll notice is that for patients who were relatively high functioning at baseline, the procedure almost never worked. So patients who had a score of 77 or higher, 92% of the time, the procedure did not achieve a minimum clinically important difference in their functioning, and in many cases left them worse off. And by contrast, patients who had low functional status were almost certain to be helped. So below a certain score, and for us, it was a score of 47, you can see that nearly every patient in that category ended up better off after the surgery. Now, together, those two quadrants really represent only about 40% of our population. But the fact that for 40% of the population, one number, a baseline functional status score, could tell us with near certainty whether the patient would be no better off and potentially worse off or helped by the procedure, I find incredibly powerful and really compels us, I think, to begin to use data like this as we work to get better results and avoid wasteful expenditures of our healthcare dollars. So NQF is looking to help support and accelerate progress toward that next generation of measures. I'm noticing the time, so I'm going to go relatively quickly here so we have a minute to talk about the social drivers of health before we turn to Q&A. But in brief, what we're looking to do really leverages what I learned in my time at Blue Cross, which is it is hard as an individual stakeholder to develop measures that ultimately can move forward and be used in a national way or even in a broad regional way because it's just hard as an individual stakeholder. So our model looks to convene a coalition of what we're calling activist innovators. So other payers like me at Blue Cross Mass who sense the urgency for getting to a next generation of measures and have been trying to do that on their own and are finding that it's just tough going. And so they're interested in doing this in a coalition model. So that's what we're aiming to do. And we're in the process of building that out now. Some of the advantages of doing it in this model include that with a broader group of providers who are at the table and involved in the development of the measure specifications and then the testing and implementation and testing of the measure, we will discover things about the measures that oftentimes don't get discovered until so far downstream after the measure's been developed, maybe even after it's been published and even endorsed, that they then become a problem because now you have to go back and you have to re-specify the measure and you have to retest the measure. Or you might not be able to implement the measure because the data aren't broadly available. We have many measures that have been endorsed by NQF that are not broadly adopted, in part because they rely on electronic health record data, and it's too challenging to extract and report those data. So we will front load the discovery of those kinds of barriers and solve them by having a broad group of providers and payers and purchasers involved from the beginning. So because of that, we believe that this model will be better, faster, and cheaper than traditional measure development, which is pictured here. So let me just draw this to a close by saying a few words about the social drivers of health, and then I'm very eager to get to your questions and a conversation. So as I said earlier, when I was sharing the Blue Cross outcomes with respect to health, value-based payment really compels consideration of patients beyond the four walls of the clinical setting. And that, I believe, is part of why it may not be the only driver, but it is a big driver, I think, of why we are suddenly hearing so much more about social drivers of health in the context of healthcare. And we're seeing organizations taking a leadership role in collecting information about social drivers, asking people about housing stability and food insecurity and personal safety. And all of that is critical. And it raises the question as to whether, where is the line about what healthcare is accountable for and can help address, and what's beyond the walls and feasibility for healthcare. That raises the issue in methodological terms about adjustment of results for social risk factors. That is a very hot debate right now in healthcare. Some of you may already be aware of that. I tried to summarize the issues on this slide here, and I want to be clear that here I'm sharing with you some of my own professional perspectives, deriving from my experiences at Blue Cross Mass and on MedPAC. This is not this slide an NQF position, so please don't hear it that way. NQF is in fact doing some important work on this question of how do we find the right balance of incorporating social risk factors in measurement models. And so there are some who say, look, when you care for a population that has higher social risk, it is harder to achieve good results, and therefore the measure results should be adjusted for social risk. And there are others who say you can't adjust the measures for social risk because then you obscure the differences in performance. One of the ways that I think you can kind of have our cake and eat it too is to adjust payment for social risk. And I was really excited to see that CMS, in its announcement a week or so ago of the new ACO program called ACO Reach, is in fact adjusting payment for social risk. They're adjusting the payment benchmark for social risk. The reason I think that's having our cake and eating it too is it allows us to account for the fact that it may well take different resources to care for populations that have higher social risk. And it either builds in those resources up front, the way the REACH program will do, by giving added budget money for those who care for that population. It can also, and these are not mutually exclusive, create higher payments for a given level of performance among those who have higher social risk. So if two provider systems achieve the same result and one has a very socially disadvantaged population and another has a very advantaged population, well, the first one may get a multiplier on their bonus, their performance bonus, and the other may just get the basic bonus for high performance. So there are a number of ways, and this is an ongoing, very fluid, very important debate right now. Love to hear any questions or comments folks have on this topic, but on any topic. So let's talk. I will take down the slides. Let's see, where do I, okay, stop sharing, and really welcome your questions.
Dr. Safran, that was a tour de force, and it was an amazing lecture. Particularly the last part was personally for me, I think, a step in the absolute right direction. Measuring the social vulnerability and adjusting payments for that is a step in the right direction. We do have some questions, and we'll go by them one by one from the audience. And I encourage everybody to put their questions there, and we'll try to go through all of them as well. But I'm going to start with, use my privilege maybe as the moderator, with one question that I know is on a lot of people's minds. We cannot improve what we do not measure. We cannot improve what we do not measure and actually risk adjust. And one of the things that's the two areas that are usually criticized or debated hotly, and when we do any quality of care measures or performance measures, is how accurate is what we're using to measure. That's one. And two, how accurate is our risk adjustment model. I mean, the first one, it seems the National Quality Forum is very much aware of and is working on it. And the second one, I'm sure they are, but I would like you to share with us the thoughts and the work of the National Quality Forum on risk adjustment to ensure we don't have perverse incentives, which we see in our daily practices as physicians, as tertiary referral center, where hospitals, physicians, consciously or unconsciously, cherry pick which patient population to take care of.
Yeah, it's a really critically important aspect of measurement and measurement used for accountability. And, you know, I'll again point to first my experience at Blue Cross, right? We were concerned about the issue of cherry picking. And if your risk adjustment model is doing its job, then you actually want it to be creating the incentive to take the most complex, the most challenging, the most difficult populations, whether those are defined from a case mix perspective or a social risk perspective or both. So that's just to underscore your point about the critical importance of risk adjustment in this work. NQF does, when a measure is considered for endorsement, the risk adjustment model for the measure is part of that consideration. So today, the way our endorsement process works, we have what's called a scientific methods panel that is made up of methodologists who weigh in on all of the technical aspects of the measure and the measurement model, including the risk adjustment model. So some of the work that NQF is doing now in this space around social risk is what is the proper place of social risk factors in risk adjustment models? Should they be in there? Always, sometimes never, and under what circumstances, and so forth. So that's a hotly debated topic, as is actually the topic of should functional status measures be incorporated in risk adjustment models. But can't agree with you more about the importance of that. And then I'll just go to your point about the underlying data as well, because I think I heard you getting at not just the importance of risk adjustment, but how do we know that the data that we're using both for our measures and for the risk adjustment are the right data? So I'll just take another moment, if I could, to address that, to say another area where we've had roughly a decade of consensus and yet very little progress is this desire to shift to measures that are sourced from the clinical record, right? I know very well from my 12 years at a health plan that most providers don't think very highly of claims data, even though I'll remind everyone that claims data start with providers generating bills. But so we know that providers don't think very highly of claims data being used for measurement purposes and really trust much more the clinical record. And so there's been consensus for a decade that we want to move toward using the clinical record for measurement, and very little progress. I'm optimistic that with some of the new regulations from ONC, including the requirement that EHRs now have capabilities not just for fire, but for bulk fire, which will enable the reporting of information on a whole population just as easily as it allows the reporting for an individual, that we can start to reduce some of the burden, but that I will add quickly, doesn't necessarily assure us that the data that we're using for measurement are better. And my own experience when we were doing an experiment with partners around the use of clinical data versus claims data for measuring things that were in our measure set, the partner system was discovering that, gee, the results using the clinical data didn't look as good as they wanted and were enormously variable. And it was a really good demonstration that the data will only get better when we use them. So we have to start somewhere and begin to use these data. But the ease of reporting is one piece, but we're also going to have to tackle the issues around the way data are input. And that's a behavior of every clinician, every day, every encounter, how we're capturing data into the EHR. If we want that to be the source of truth used for measurement, it's going to take some cooperation and some work on everyone's part. So I hope that was a very thorough answer to your question.
Yeah, no, that's fantastic. I mean, there's so much more to talk about, and I think we should have you one more time in the future to talk specifically about how to measure claims data, clinical database. Fascinating topic, but we have a lot of questions. So, Dana, I'm going to ask you if you can maybe answer them shortly so that we out of respect to everybody, we go through their questions. I know some of them are actually topics by themselves. First question is from Michael Tassi. Were the pay for performance measures that led to the savings based on shared savings? I think he's talking about the slide when you showed the saving for pressure ulcers and versus drug reactions and surgical site infection. And he's asking if the pay for performance measures that led to these savings were on shared or penalties for the iatrogenic conditions listed.
That's a great question. And I do have a short answer because I don't know the answer for that particular slide. If it was for the other slides from the AQC or from the CMS programs, I would know the answer, but I'm afraid that I don't know for that particular slide.
Got you. I got a question here from Bethany Daly. Do the models, I'm assuming, one of the models you showed, do the models for payment consider financial incentives, direct payment to patients, if they adhere to process measures behaviors of their own? So this is like a direct payment to patients to incentivize outcome.
Yeah. So I love that question. And the answer is no, that they don't. Not for health behaviors. And there's a really, I would commend you to have for one of your quarterly speakers, Dr. Kevin Volk. Kevin is one of the most renowned healthcare behavioral economists in the country, if not the world, and has done work on this question of incentivizing individual people for health behaviors. My own view, and I'll share it, is that I don't think it's a good road for us to go down, because I think that we then have to keep upping the dollar amount to ensure that individuals keep doing the behaviors that we want them to do. And I see a big difference between paying patients and paying clinicians, right? Or provider organizations. Provider organizations, we are going to pay. You are delivering a service, you will be paid. So the incentives around, how do we want to incentivize certain behaviors is an appropriate part of the conversation. Right now, today, patients are not paid. So, it's rather like the decision I made not to pay my children to take out the trash, because I knew there would come a day where they would say, for $5 a week, it's not worth it to me. So take out the trash yourself.
Yeah, that makes sense. That makes sense. There's a few more questions, but I'm going to choose two of them and I can put them in one question for you, and we'll make it the last one. The two questions, one is from Rahul Jindal in Washington, one is from Rashri Gartland here in Boston. The first one is asking about if there is any risk and adjustment for academic productivity of providers. I guess this is not a hospital reimbursement, but physician reimbursement. And the other one is, are there any incentives for clinicians participating in programs that help mitigate social barriers for high-risk patients? Have you discussed any of that? So kind of like incentives directed at physicians or providers directly, one related to academic productivity out of the clinical work, and the second one is about participation in programs that look at social barriers for high-risk patients.
Yeah. Great. So I'm glad you combined them. And what I would say is, all of what I've described to you is about payment from a payer, a private sector payer like Blue Cross, or a public sector payer like CMS, to a healthcare system. It is not about how that system chooses to create payment for its individual clinicians. And so how a system then takes those incentives and builds it into its payment model is something that is largely unstudied, but critically important. And we do know that most systems, even ones that are predominantly now in value-based payment with their public and private sector payers, are still primarily paying based on RVUs. So, you're incentivizing volume while accepting responsibility for managing total cost of care. It's really a crazy paradox. So I love both ideas, rewarding academic productivity and rewarding social engagement to help reduce barriers. Today, that really is something that can happen as the system defines its compensation model.
Dr. Safran, in respect of everybody's time, I think there's so much food for thought. I really want to thank you so much for engaging us today. I want to wish you the best of luck in the in your very big role as the president and CEO of the National Quality Forum, and we're always ready to collaborate with you and work with you anytime you need. Also want to say thank you for the more than 125 people who attended today, and to Olivia Seekins, our Compass program manager, who really pulled this through, and I look forward to seeing you around.
Thank you so much for the opportunity.